السلام عليكم ورحمة الله وبركاته. اليوم نتواصل معكم في المحاضرة التالية بعد ال Normal Anatomy اللي هي Recognizing Deviation from Normal Radiographical Anatomy. And here the dental hygienist and the dental assistant should possess the ability to recognize the deviation from the normal. Developing this skill requires practice. Although identifying deviation from the normal radiographically is important, a diagnosis cannot be made from a radiograph alone. يعني صحيح إيش كده هو مهم إنه أنت لازم تتعلم على recognizing any deviation from the normal, but you should keep in your mind that is the dental radiograph alone may do nothing, and dental radiograph, it is an aiding device in the making the final diagnosis, which is also depends on the clinical examination also. Common radiographic observations. Thus, the dental hygienist and dental assistant should be able to identify radiographically include the appearance of restorative materials, developmental anomalies, periapical pathology, and other pathological conditions, and also the effects of trauma. وراح تجي ناخذها عندنا هسه المواضيع بالتدرج. Metallic restoration materials such as amalgam, metallic crowns, retention pins, post anchor, and silver points appear radio-opaque and are distinguished from each other by their size and shape. Non-metallic restorative materials such as composite, porcelain, base material, and Ketteberg appear less radio-opaque than the metal. A composite material may appear slightly radio-opaque or radiolucent. So, we may take the following dental radiograph and we explain what we seen in each item. Starting with this radiograph, here showing the dental materials frequently used in dental practice. First of all is the amalgam restoration. Second is the porcelain fused to metal crown. Third is the post anchor. Four is the Ketteberge. Five is the base material or lying material. Six is the full metal crown, which is the posterior abutments of the 3-unit bridge. Retention pin. This is the projection of the retention pin. And finally, the metallic ponting, which is a part of the 3-unit bridge. This is bridge have 3 units, 2 ponting and one ponting and 2 abutments. Sorry. Here, this dental radiograph show the composite material, which is radio-opaque composite, and second is a radiolucent composite. This is a very old material used for anterior restoration, which is the semi-radio-opaque composite and radiolucent composite. Nowadays, it is all replaced with a radio-opaque composite. 3 is the porcelain fused to metal crown. هنا عندنا احنا نسميه over exposure of that radiograph. That's all over the radiograph show more dark area than radio opaque area, and that the overexposure or darkness of this radiograph make it especially difficult to view the porcelain on the left lateral incisors اللي هو هنا. لكن the overexposure makes it possible to make the cement under this crown. The cement under this crown. So, second radiograph, which is a bite-wing radiograph, show an amalgam overhang, and this is the overhang due to a mistake from the dentist who not make a proper wedge placements in a retainer. So when you condensing the amalgam go out the outline of the tooth, make it appear as an overhang, and this overhang it is a mistake, making a more food accumulation and impair the self-cleansing of the interproximal area. Second is the base material used under the amalgam restoration. From this and previous radiograph, note that there is a many shape and size of the amalgam restoration. Here, this is an amalgam fragment embedded in the soft tissue, properly left after an extraction. Legally called an amalgam tattoo because the amalgam fragment produced a brownish purple spots on the gingiva. يعني هنا مثلا اكو ممكن انه من الخطأ انه نسوي نفس التوث او نفس السايد نسوي extraction and amalgam filling، او انا اسوي extraction بس during extraction اسوي fracture in the adjacent amalgam and piece of that amalgam will retained in the socket, and finally stressed on the ridge, and sometimes it is appear all around the extracted side, and the two side the jaw start to repel its outside. So you can see a fragments of amalgam restoration appeared in the gingiva, and thus cause a brownish discoloration. We called it or bluish purple or grayish spots on the gingiva. We called it amalgam fragment or amalgam tattoo. Here we see a stainless steel crown, and this is a crown may be used frequently in deciduous teeth during restoration of badly carious teeth, and in the previous they can do as a crown for an very badly carious tooth to restore the normal shape. Now it is infrequently used and it is replaced by ceramic crown. Here we see the retentive pins, and this is retentive pin help retain the radiolucent composite restoration, and here we see a small radio-opaque amalgam restoration. Here we see a small radio-opaque amalgam used nowadays consider a non-aesthetic restoration to use in the interior, and nowadays all over it's replaced with a composite or aesthetic restoration. Here, an tooth with in endodontic treatments, endodontic treatment, we here you see the post and core within the root canal, and two is the cataberg. Endodontic filling material may also be present with a post and core restoration is observed. Three is the amalgam restoration. And now we can use, we can explain the post treatment nowadays used. Nowadays you can see many types of post and core. First, start with uh, what we call a fiber optic uh, post, and here the preparation used to making a site with placements of fiber optic post after using of bond and placing some blotting agent and forming a core with a composite. This is fiber optic post, and as you know that the fiber optic appear a somewhat radio opaque material. It is difficult or it is different from the underlying cataberg. So after we treating the tooth with cataberg, we removing some cataberg and put the fiber optic, which is appear a somewhat radio opaque and dental radiograph, and complete the tooth with a composite. This is an radio opaque composite. There is another types of post and core as it is seen in the previous radiograph, which is this, and this is made by making a preparation inside the tooth, and we make an impression and making a negative cast, and on the cast we made a single post and core object which is luted inside this root and make a final ceramic crown over it, and that is appeared in clinical practice. This is post and core in a single body which is placed inside the endodontically treated tooth, and here the ceramic crown placed over that core. There is another type of uh, post and core which is a screw, and here the dentist make a big mistake by placing the screw inside a non-endodontically treated tooth, just a screw, and that screw make this inflamed tissue to promote an infection in the preapical area, and that infection make a discharge of pus outside the tooth, and this is the cadaver used to uh, locate the origin of that of that tooth. Here, after removing of that screw, making a complete endodontic treatment and placing the screw. This is the metal screw, which is maybe in a gold made from a gold or stainless steel screw. And here is the placements of a screw inside a tooth with endodontic treatment. Here also a cataberge and screw. Here a non-treated endodontical treated tooth with a screw. Here you can see there is a perforation during the placements of the screw. During the preparation, the dentist make a perforation in the bifurcation area and make the screw passing through the tooth to the underlying bone. All that may make an infection. Here we see uh, an external resorption caused by trauma from orthodontic treatment. Uh, Not any other orthodontic treatment make a trauma, but unplanned force, unplanned use of force during orthodontic treatments, like exerting more force than it is need, or moving a tooth uh, with a fast acceleration of the force. All that make an exerting an abnormal force to the tooth, make it is forming an external resorption. You see that there is no apex or losing of 1/3 of the tooth. When you see, of course, it is seen in the lateral, central, and lateral, and this is all over external resorption. This external resorption is caused by application of trauma during orthodontic treatment. This is a radiograph showing an implant inside the jaw with a crown over it. This is a surgical material, which is a surgical wire used to treat a fractured mandible. This patient suffering from a fractured mandible, and the surgeon suture it with a fracture with a surgical wire. Mandibular fracture indicated by the radiolucent line. This is the radiolucent line indicate that there is a fracture on that side and treated by surgical wire. Now we starting with developmental anomalies that may record on radiograph, including anodontia, supernumerary teeth, mesodense, dense and dentine, hypersymatosis, dilaceration, pterodontia, and gemination and diffusion. Here there's a congenital missing. A second premolar did not develop under this primary molar, and there is severe caries in the lower 7 and severe caries in the deciduous A. As I told you in the previous lecture, you should know the normal anatomy, the number of the tooth you should see in the dental radiograph to decide that there is congenital missing. As you know, this is lower 6, lower 7, lower 8, and here you should see the lower 5. So if you cannot see the lower 5, and this is the small molar teeth represent what we called it an E, which is the second deciduous molar, and there is no permanent molar. This is called the congenitally missing teeth. Here there is a supernumerary because this is the canine 4, 5, 6, 7, and this is the supernumerary, and also it is impacted 1. supernumerary. طبعا السوبرنيومراري هو فد addition number of tooth and is named according to its location. If the supernumerary located between the two central, it is called mesodense. If it is located in the posterior area, either it is called paramolar, and it is called distomolar. All that it is called supernumerary teeth. All that is shared the same name. It is supernumerary tooth. Supernumerary, sometimes it is appear similar to the contralateral tooth. يعني هذا التوث يشبه كلش الفور والفايف. ف بأقسام اللي هو supplementary tooth يسموه supplementary tooth، يعني هذا التوث يشبه الفور والفايف عينه، أو يطلع 6 و7 هو يشبه ال6 وال7 عينه. أما الميزودنس هسه نجي لا هو فشي يشبه التوث لكن على شكل صغيروني وسايز صغيروني. مثلا هذا هسه يسموه supernumerary teeth. It is tooth-like structure with very small size located between two central. This is the central, lateral, and canine. So this supernumerary teeth is located in the middle between the central incisors. Some mesodense located with inverted seated tooth, which means that the crown is apically and the root is coronally. The root is coronally and the crown it is apical. All that is called the mesodense. And this is the natural appearance of mesodense. It is a screw-like shape, screw-drive-like shape, located between the two central, giving an ugly appearance to the patients and treated it by extraction. The second is the dense indentine, which is an invagination of the enamel within the body of the lateral incisor. Within the body of the lateral incisor. Here we see there is a bulging in the root of the tooth, which is called a bulbal formation. It is a bulging in the tooth, and that's a bulging in the tooth is caused by overgrowth of the cementum on the roots of the molar. On the roots of the molar. Here we see the dilaceration of the tooth. Dilaceration, it is the sharp bend in the root of the second premolar. Sharp bend. And this is sharp bend may be related to a trauma during growth or it is naturally appeared. The number 2 represents a torus palatinus, which is a radio opic benign overgrowth of the bone in the middle of the palate. This position it shared it with zygoma or zygomatic process. So we need to see this patient clinically to make a decision that is uh, torus palatinus. Okay. Also, there is this radiograph is very famous radiographs. You frequently see in the internet, which is a dilaceration of the upper lateral. This is also is a dilaceration to the lower wisdom teeth, making it is very difficult to extract without fracture. Here is the fusion of the tooth and two joint adjacent incisor. Two joint adjacent incisors. You can see there is two crown, two roots, and diffused in the middle. The second, this is difference between fusion and gemination. Gemination, that is the same tooth undergo a division in the middle, while fusion is the fusion of the two separated tooth in one side. This is the gemination. This is the gemination. This is one tooth deviated in some area of the crown. This is the gemination. And this is the fusion. So this is the fusion. This is the fusion. This is a gemination. This is a gemination. This is the fusion. This may affect also the deciduous teeth. A second uh, deviation from the normal. This is the normal tooth. This is hypopterodonts, mesodonts, or hyperterodonts. That means this tooth have a very long shank, very a long shank with a narrow or a short root. This is called tarodontism. Tarodontism. The radiographic appearance of the apical disease. Periapical abscess, granuloma, cyst, all appear radiolucent and cannot be distinguished from each other radiographically, while the decision depends on the histopathological specialist, which is seeing the biopsy and the microscope to decide if it is there is a granuloma, a cyst, or an abscess. All that scenario, all that story start with deep caries, it's frequently seen, deep caries, and should start with widening of the periapical area, widening of the periapical area. It is called a periapical periodontitis because the periodontal ligament it is a part of the periodontia. Periodontia. So it is an infection of the periodontal ligament but at the apex. So it is called periapical periodontitis. And that periapical periodontitis may become very large to show a periapical pathology. So the caries on the distal side of the left central incisors make a round radiolucent lesion that may be a perical abscess, maybe a granuloma, or even a cyst. But if that radiolucent area become more than 2 centimeter, we can see that is most likely a cystic lesion. While a lesion with that size, it is difficult to recognize while it is a perical abscess, granuloma, or cyst. So you can see a very wide area of infection with a widening in the periodontal ligament and disappearance of the lamina dura. Disappearance of the lamina dura. Now we can see the integral cyst. The integral cyst, which is a cyst involving the impacted third molar. Impacted third molar. Note that the expansion and the thinning of the cortical bone of the mandible in the response to the cyst. In this image, the image receptor was properly placed in the vertical position instead of the usual horizontal position to better record this condition. So this lesion, it is called the integral cyst. It is one type of the mostly seen cyst in the jaw, and this cyst appear with a space surrounding the impacted and erupted tooth. Frequently, it is the lower eight or the canine, because this teeth is the last teeth appear in the jaw. So when the teeth found no space to erupt, it is become impacted, and sometimes they forming a cyst around the tooth, and that cyst may exerting a pressure with a resorption of the bone and forcing of the inferior apical nerve, and sometimes they exert a pressure to forcing the tooth inside the ramus. This side, what we talking about, which is the incisive canal cyst. This is the anterior nasal spine, the nasal septum, the anterior border of the nasal cavity, and this is a dentulous patient. Here the site of incisive foramen, which is become very large due to forming of incisive canal cyst. And this is a raw outline the incisive canal nasopalatine cyst in the edentulous maxilla. This is another type of long-standing cyst, and this is maybe one of the number of teeth. The famous one is the residual cyst. Residual cyst, that means that this tooth, infected tooth, which have a periapical cyst, radicular cyst, and the tooth undergo an extraction without cleaning or curation of the extracted teeth, that the daughter cells of the cyst remain in position, and after extraction they forming a residual cyst. And we see that this cyst uh, having a long period due to the forming of enhanced margin of the cyst. You can see in clear way that the border it is very radio opaque, and that means that this cyst become um, taking more time to grow. This is another example of residual dentigerous cyst, sorry, around the impacted lower canine. You see the huge resorption of the bone with force to the inferior nerve and forcing the canine to lower border of the mandible. There is another uh, abnormal situation recorded in the dental radiograph, which is the internal resorption. Internal resorption. This is internal resorption. It is unknown, unexplained situation that may affect some tooth. It is called iatrogenic without any cause, uh, or idiopathic internal resorption, which is resorption start from the inside the tooth. It is this tooth. It is difficult to be treated with endodontic treatment because it is difficult to make this uh, resorbed site filled with obturator. Also, this is some type of internal resorption that make all over the canals, all over the canals. And the second type of resorption is the external resorption. As we taken previously, external resorption may take place during an orthodontic treatment with the trauma to the tooth. Sometimes it is be uh, idiopathic without any cause to see that this tooth undergo external resorption, taking the distal root of that tooth. This is a retained root, which is the main root after extraction of the lower eight. So this tooth, the jaw repealed its outside to reach the jaw of the mandible or the edge of the mandible, and this is a radioapic retained root, which is a fragment in an extraction site. Also, this is the fragment of the extracted tooth remain in position without repelling to the outside. We see you can take it due to during the surgical lectures that when we facing a fracture no more than a 2 millimeter and it is difficult to be extracted, you can leave it in a place and the tooth or the jaw start to resorb it. Now we take a radiographic appearance of the calcification and opacification in the jaw, starting with ceololith. Ceololith is a radiopaque stone seen in the duct of submandibular gland or salivary gland. And here the patient is edentulous, and this is the site of submandibular gland. So it is a calculus forming a stone or what's it called a ceololith inside the canal of the submandibular gland. Here there is a condensing osteitis which is an radioopic sclerotic hardening of the bone inside this. And this is also it is an idiopathic response of the jaw to forming more bone, more condensing bone between that two teeth. Osteosclerosis is a diffuse idiopathic osteosclerosis which is not related to the tooth. Previously, this is condensing osteoarthritis is relating to some tooth, while osteosclerosis is not related to any tooth, just is floating in the mandible. So, also we can see radiographic appearance of odontogenic tumor, and starting with ameloblastoma, which is large radiolucency, making a resorption of the mandibular molar root caused by the pressure of the trauma. And this is another type of ameloblastoma, which is show the uh, soup bubbles appearance of the ameloblastoma. Here, this is an odontoma, which is consisting of small misshaped teeth located within the radiolucent fibrous capsule. So it is we can differentiate it because odontoma having a radiolucent capsule, while a sclerosing or condensing bone it is fused with the neighbor tooth. Here we can see the fibrous dysplasia, which have two uh, two shape. The early shape, which is the forming of radiolucent area, and after that it is formed to a late stage, which lead to the development of radioopic material. In both cases, we can see that the tooth is a vital tooth. So here we decided the appearance or the importance of the clinical examination in comparing with a radiograph. If you see that this tooth is non-vital, you can see that this is a periapical lesion, cranioloma or cystic lesion or abscess. If you know that this tooth is vital, you should know that this is a periapical or cemental dysplasia. Finally, we reach to the radiographic appearance of the trauma. The most common injury observed in dental radiograph, which is the fracture of facial bones and teeth. Fracture lines are thin radiolucent lines that demarcate the region of the bone or tooth separation. Fracture may on occasion have a similar appearance of the neutron canal. Radiograph will sometimes reveal the presence of the foreign body. Here, the patient with a trauma having a foreign body. يعني دول البيشنات اللي مرات يجوكم للعيادة مثلا عنده تروما، تاخذ له اكس راي تلقى فات فورين بادي. هذا الفورين بادي قد تكون قطعة من حديد، قطعة من قزاز، قطعة من انفجار معين. هذه تطلع بالراديوغراف. زين. Here a tooth with horizontal line of fracture due to the trauma to this central incisor, make it the fracture in the middle. Here, this is the extrusion of the tooth, which is the tooth come out from its socket due to a trauma, and we can see the original place of the tooth, and this is the distance of extrusion of the tooth due to a trauma. In reverse, there is a second type of trauma, which is a direct blow to the tooth, make it to be intruded inside the jaw. intruded يعني السن يطب لي جوا بعد الزايد، وذاك لا يطلع السن لي برا. كل واحد حسب التروما. أيضا أي سؤال ممكن يدور في ذهنك بعد ما تشوف المحاضرة ممكن تكتبه على اليوتيوب وأنا أحاول أنه أجاوب لك إياه. أيضا هذه المحاضرة راح تنزل محاضرتكم الأربعاء هي راح تنزل في وقتها. وبالمناسبة أنه إن شاء الله راح نفس المحاضرات إن شاء الله بعد ما هذه الأوضاع تخلص وتنتهي بإذن الله وبسلامة الجميع، راح نكون مستمرين في تسجيل المحاضرات في الكلية أثناء أداء المحاضرة، وتبقى المحاضرة تسجل وتنزل اليوتيوب للأشخاص اللي ما يتمكنون أنهم يوصلون للمحاضرة ويحضروها تبقى المحاضرة، أو أثناء الامتحانات ممكن تراجع بدل أنه أعطي الباوربوينت راح تبقى المحاضرة مستمرة في التسجيل، سواء هذه الظروف وإن شاء الله تخلص هاي الظروف أو بعد ما تخلص هاي الظروف بإذن الله. شكرا جزيلا.